Hi, this is Professor O'Connor again, and this is part 4 of your pre-class assignment, and this section will be talking about croup. Croup is an acute viral illness. LTB, or laryngotracheobronchitis, is the most common form. It affects children between the ages of 6 months and 6 years, and it peaks usually for children around 2 to 3 years. It does affect boys more than girls. Pathophysiologically, the parainfluenza virus is one of the most common causes. It occurs during the fall and winter months, and the other causes can be influenza, RSV, which is respiratory syncytial virus, and mycoplasma. These children have copious secretions and have increased respiratory distress. Diagnosis is made by history and clinical signs. So getting a detailed history from the parent is very important. Obtaining a throat culture and visual inspection are actually contraindicated because it could cause the epiglottis to close and cause an airway obstruction. Radiographic study may show a subglottic narrowing, and that is known as the steeple sign, and pulse oximetry would show hypoxemia. These children present with having had a upper respiratory infection for a couple days prior to croup, and it progresses to cough and hoarseness. Fever, maybe, maybe not. They will be tachypnic. They will have inspiratory stridor, which is an indication of upper airway issues, and they will have a seal-like barking cough. It sounds exactly like sea lions. Medical treatment is based on maintaining and improving respiratory effort with medications and oxygen. Oxygen would be used if the SpO2 is less than 92%. If the child is being treated at home, they are administered PO corticosteroids, and just recently the recommendations are not to use cool mist. If the child is hospitalized, they may receive racemic epinephrine, which is nebulized. They may receive corticosteroids, IV or by mouth, nebulized budesonide, and the child may need intensive care unit and intubation if they go into laryngospasms. I have 2 YouTube video clips that the hyperlinks will be placed just below this video clip so that you can read them. You are responsible for the content within them. And one is showing you a baby with croup, and the other is showing you stridor and retractions. This is the third YouTube clip that you are responsible for. It is actually in this section as well as in the bronchiolitis section, and it is describing the differences between bronchiolitis and croup. The main issue is croup equals upper airway, bronchiolitis equals lower airway. You are responsible for this information. So for nursing assessment, you want to note what the age of the child is. In general, it can be 3 months to 3 years or 6 months to 6 years to present with LTB. The history may reveal a cough that developed overnight. That is the most common presentation. The cough sounds like a barking sea lion. So you want to inspect for the presence of the child having had mild upper respiratory infection symptoms. The temperature may be normal or mildly elevated, and you want to listen for the inspiratory stridor. Observe for substernal retractions, auscultate for the lungs for adequacy of breath sounds, and it is usually diagnosed based on history and clinical presentation. An X-ray may reveal a steeple sign, and that is used to rule out epiglottitis, which is one of the forms of croup. So for nursing management, I've divided it up as the child being treated at home versus the child being treated in the hospital. So this is the child being treated at home. The parents should be encouraged to keep the child quiet and discourage crying. Allow the child to sit up and sit in the parent's lap and arms. Encourage fluid intake. And recent studies do show that a steamy shower is not helpful. They need to administer PO corticosteroids if it's been ordered. And they need to call the healthcare provider if the child's breathing becomes faster, they have retractions or difficulty breathing, they have nasal flaring, Their lips or nails have a bluish tint. The cough or stridor does not improve. That restlessness increases or the child becomes confused. And that the child begins to drool or cannot swallow. Treatment in the hospital, we want to keep the airway open. And to do that, we want to keep the child calm. And that may mean that the child spends most of its time on mom's lap. Oxygen saturation should be on at all times. That's what AAT stands for, at all times. And we want oxygen that's going to keep the O2 sat greater than 93%. We will administer medications, specifically nebulized racemic epinephrine. Corticosteroids will be ordered IV at first, or PO if they're taking PO liquids. And we want to keep them well hydrated. These children may not be drinking, so they may need IV fluids to begin with, and then as things improve, they can be transferred and changed over to PO liquids. This is the end of the croup section, and there are a few video clips for you to watch after this, and then you can move on to part 5, which is bronchiolitis.